So we're going to talk about the neuroendocrine tumors of the lung, the neoplasms of the lung. Unlike what we talked about this morning in the adenocarcinomas, there's not a whole lot changed in the WHO, the neuroendocrine tumors, though there's a lot out there that is on the verge of changing. It's mostly in the molecular spectrum, and we can talk about that in the end. But the nomenclature, the terminology, and the diagnoses are pretty standard. We'll talk a little bit about the morphologic features on each of these tumors. We'll talk a little bit about the immunohistochemistry, because I think that's something that's probably very practically helpful. How many antibodies do you want to throw on these tumors to get to a diagnosis? And I'll present what I do. And then, though Ki-67 is not officially used, as you know, in these tumors, unlike other neuroendocrine tumors throughout the body, we'll talk about how you can use them. And again, I think the next WHO will have a lot, both in regards to the Ki-67 as well as how we use molecular testing. So let's start off with a case. 66-year-old female with a history of cough, wheezing, and some productive sputum. Chest x-ray with a subsequent chest CT showed what they called a left hilar mass at 4.5 centimeters. And again, this is a cross-section of a CT, and you can see quite a large mass here. Somewhat proximal, has a little bit of an infiltrating look to it that we don't know, because that could just be obstructive changes and inflammatory changes in the lung adjacent to it. The patient underwent a left pneumonectomy because of the location and the size of the tumor. This looks small for a left pneumonectomy, but that's because a lot of this lung is collapsed down because of the obstruction of this quite large tumor. Here you can see mirror images of each other. You can see this tumor kind of tan white infiltrating out here, continues over here. And you see what you see very commonly in these very proximal tumors, especially carcinoid tumors, this mucus plugging and a lot of inspissated mucus here. Pathologically, we see little nests of rather hyperchromatic cells. If you look a little bit closer, you can see there's some cytologic atypia. There's what we would call punctate necrosis, as well as some single cell necrosis here. There were areas of it that were quite spindled. You can see here. And it was diffusely positive for chromogranin, especially in that spindled area.